Okay, so thanks for the kind introductory words, and good afternoon, everyone. I'm very happy to present you some of the things we're currently working on in my lab. And this is very much work in progress, so there will be a lot of unpublished data, which I hope you appreciate. But I also would like to ask you not to distribute, screenshots or so further, just not to jeopardize any of my PhD students from graduating. So yes, the title of the talk, as Katja just said, is Understanding Cancer in Dogs Using the Latest Technology to Gather Insights into Soft Tissue Sarcomas. And you probably all know that soft tissue sarcomas are very frequent and clinically relevant tumors in dogs. They are a heterogeneous group of mesenchymal tumors that make up roughly 15% of all canine tumors, which are located in the skin or the subcutaneous tissues. And among the most frequent subtypes, maybe I can use my laser pointer here, just a second. No, wait, laser pointer here. We have here a list of some of the most frequent subtypes that we find in dogs, which are perivascular wall tumors, peripheral nerve sheath tumors, undifferentiated sarcomas, fibrosarcomas, and myxofibrosarcomas. The important thing to mention here is that this classification is mostly or almost entirely based on histomorphology, which of course means that you're trying to define its appearance under the light microscope. Here we have an image of a fibrosarcoma, a typical one, and here we have one of a typical myxofibrosarcoma. But of course, these are very nice cases, and in most of the cases, the differentiation between the subtypes is much more difficult than these two examples here show. So we are going to have a look at whether this histomorphological differentiation really helps us very far. And I would like to suggest that we need to do better than that, or better than what we're currently doing. So the challenge number one when it comes to soft tissue sarcomas in dogs, really from my point of view, is the lack of molecular data. So we only have quite a few defined entities. We have these 5 and then a couple more, but give or take a dozen different soft tissue sarcoma subtypes which are known in dogs. And as I just said, diagnosis is mostly based on histomorphology. Why am I saying this, or why am I saying that this is a problem? Because we know from the human side of things, so in humans, soft tissue sarcomas are classified also using molecular diagnostics, and at the moment, the classification comprises more than 150 different subtypes. And I don't think that the dog is so much different to the human species that we can just simplify everything into a couple of very simple diagnoses, let's say. So the problem is really that we have no molecular markers, or hardly any molecular markers, to really define subtypes in dogs. And the question is also, as I just said, how many subtypes do really exist in dogs? We have no clue. And also because they're very difficult to differentiate based on histomorphology, this leads to a huge amount of diagnostic inconsistency. So really we have tried several times already having different pathologists looking at the same tumor, and you get a wide array of different diagnoses back. And this is not to say pathologists don't do a good job. This just reflects what the human pathologists have kind of realized quite a while back, that it's just not good enough to have a look at these tumors only using histomorphological criteria. That because we only have a few defined entities, and we don't really know whether these are entities at all on the molecular level. This also leads to a lack of reliable prognostic markers. So we don't really know which of these tumors is going to behave benign and stay local and be cured with a quite low amount of therapy, and which one will really behave aggressively and go on and metastasize very quickly and killing off the patients. So we kind of have a problem really that we don't know what these soft tissue sarcomas really are. And the second challenge when it comes to soft tissue sarcomas is really the inadequate therapy. The current mainstay of therapy across all subtypes, and this is also true, for instance, for human soft tissue sarcomas, is the accurate surgical excision. So that means if you get the tumor out completely and don't leave any tumor tissue in the patient, you have de facto, you have cured the patient. The problem, however, is that the definition of the margins by eye is almost impossible. And these tumors like to grow in a very infiltrative way. So they show a locally invasive growth pattern. So they kind of infiltrate the surrounding tissue, and you don't really know where the tumor ends and where normal tissue starts. This means that in a lot of cases, if surgery is undertaken, this leads to unclean resections. And of course, if we have an unclean resection, which means that we still have tumor tissue remaining in the patient, this can lead to tumor recurrence and also metastasis, because very often tumor, when it recurs, it behaves more aggressively than the primary tumor. This is also something which on the human side of things is called whoops surgery, which happens surprisingly often, which means nothing else than that the primary caretaker has, decided to remove the tumor, maybe just cut a small part out of it because they didn't realize it's a soft tissue sarcoma, and then it comes back with the diagnosis and with unclean margins. Yeah. So to counteract this problem that it's very difficult to get these resections, the surgeons try to use very large margins in the hope that they can, using very large margins, that they can really get the tumor out completely. The problem is a bit that if you use very large margins, and this is just an example from our animal hospital in a soft tissue sarcoma in a dog, where here you have a 3 centimeter margin around the palpable tumor mass, you can already recognize how large this hole is. And if you, for instance, think about a small dog or even a cat, in cats you have to use 5 centimeter margins, those holes become even larger, and this really can substantially contribute to patient morbidity. And sometimes this means that tumors become non-resectable, so that the surgeon really says, I can't resect this tumor properly because I can't have the margins I need. So despite those huge margins that are used, these tumors tend to recur in up to 75% of patients, and up to 30% of patients experience disease-related death. So it seems that we clearly have to do better to try and, treat these patients or support the surgeon to treat these patients. Now, soft tissue sarcoma therapy could be significantly improved by novel targeted modalities, such as targeted delivery of cytotoxic agents or theranostics, or even CAR T cells to engage the immune system. And what you could also use is you could improve surgical resection using so-called real-time near-infrared imaging. This is exemplified here in this lung tumor example. So what is done here is you inject the patient with a dye, which it accumulates specifically in the tumor tissue, and this dye is coupled to a near-infrared fluorophore. And because the dye accumulates specific tumor tissue, the surgeon can then use a camera which will show during the surgery in real time whether there is still fluorescent tissue which is left, or whether everything has been removed from the patient. The problem really in using these kind of approaches, any of these approaches, you need to know what your tumor expresses, which is not really expressed at the high level in the normal tissue surrounding your tumor. And while we have quite a good idea what these targets might be for the classical epithelial tumors, we have no clue what soft tissue sarcomas express, which differentiates them from the healthy, normal soft tissue. So which targets differentiate tumor from healthy peritumoral tissues is one of the key questions. So I just summed up here the most important, I think, open questions. It's not the only ones, but I think the most important ones, which I'd like to touch upon. First of all, what characterizes the different soft tissue sarcoma subtypes on a molecular level? Are there more molecular subtypes than we currently recognize? And which targets differentiate tumors from healthy peritumoral tissue, so we could start developing those kind of therapeutic modalities. And then maybe a fourth question, how can we start answering these questions? And to specifically analyze different tissue areas from clinical tumor samples, we use a technique which is called laser capture microdissection. So this technique allows you to use formalin-fixed, paraffin-embedded archival tissue samples to then define, so you take a 10-micron section or even thinner section of your samples, just as you would to do a histology. And then under the special microscope, you can define exactly which areas you're interested in and cut out only these areas. And these areas, so this tissue which comes here, we can then start analyzing in detail. And when we started doing this, we played around a bit with quantitative PCR, which is a very not high throughput way of measuring RNA levels. And then we moved on to develop approaches to analyze these tiny tissue pieces using RNA sequencing. And we also started to use a so-called LC-MS, which sounds like a funny abbreviation, but it actually just allows you to look at all the different proteins which are present in that sample. So we can now get the molecular fingerprint from the point of view of RNAs and also of proteins in these tiny tissue pieces. And we've applied this workflow now across many different tumor types and also in other types of tissue from both humans and dogs and cats. And here we're obviously talking now today about the soft tissue sarcoma aspect of it. So let me move on to the next slide. So to tackle the open questions, or to try to start understanding what really soft tissue sarcomas express or how they are kind of characterized compared to the normal healthy tissue, we did a proof of principle, which we used 30 cases of canine fibrosarcoma. FSA stands for fibrosarcoma. So we went into the pathology archives here and we took out 30 different cases which were diagnosed as fibrosarcomas, and we isolated tumor tissue. And also from the same cases, we isolated normal adipose tissue, normal connective tissue, and also skeletal muscle. And then we did this protein analysis just to see what kind of different proteins we could find in these samples. And this is just a graph, a bar graph showing you the average number of proteins detected, and that analysis was actually run in 22. So because the analytic pipelines are developing like as we speak almost, when we ran this data set again through the analytic pipeline, we are basically at double the amount of detected proteins now. So we can detect roughly around 5,000 to 6,000 different proteins in these tumor samples, and then also in the respective connective tissue, adipose tissue, or skeletal muscle samples. So here on the bottom right, you can see a so-called principal component analysis, or PCA, of the data. because you can imagine that if you have 2.5 or even 5,000 different proteins across so many tissue samples, it's a bit tricky to try to show or try to start analyzing. So principal component analysis is a way to identify the main components of highly complex data sets, which account for the largest variation in the data. So here, every sample that we analyze represents one dot in this 3D grid. And the samples coming from tumors are labeled in red. Then you have the ones in green are connective tissue samples. The purple ones are coming from adipose tissue. And then we have the blue ones as skeletal muscle. So what you can see from this is that clearly all the different tissues, you can clearly separate them because they kind of form different clouds, if you want. So this really tells you that the tissue type that you analyze is the major source of variability in the data. And it also tells you that these tumors, you know, across those 30 different cases of fibrosarcoma in 30 different dogs, which I think it was 28 different breeds, which were included, they behave all very similarly, regardless of the breed background of the dog. And the last thing the kind of deduce from this is that the tumor is definitely different than the normal tissue around it. So this gives us hope it should be possible to identify, you know, things which are specifically expressed in the tumor and not in the normal healthy tissue around it. So we've now used this method to work our way through the most frequent soft tissue sarcoma subtypes in the dogs, namely the fibrosarcomas, the myxofibrosarcomas, the perivascular wall tumors, and the peripheral nerve sheath tumors. And we've done, you know, the approach I just outlined to you. So we've analyzed RNA and protein from tumor, adipose, connective, and skeletal muscle. And this just gives you a large number of samples that we've analyzed at the moment. We are also currently adding 30 samples of the undifferentiated soft tissue sarcomas in dogs, which are basically the ones where no one can really tell you what they are because they're undifferentiated. We're also having a new, very fresh data set now on hemangiosarcomas, which you might know that they're really big killers in dogs. And we're analyzing histiocytic sarcomas, which are specifically, for instance, in Bernese mountain dogs or flat-coated retrievers, real killers. We also have data, and I won't go into detail on this, on human fibrosarcomas and myxofibrosarcomas, as well as feline fibrosarcomas. But we don't have enough time to go into all of that today. Good. So this kind of the overview of what we're currently working on, and you see down here that it's all unpublished. The feline story is at the moment under revision, so we hope to be able to publish it soon. But I will show you here now an example of what we can do or what we hope to be able to do with this data. So this is the proteomic data from canine perivascular wall tumors. So it's the histologic diagnosis perivascular wall tumor. And on the left here, you can see a so-called heat map of unsupervised clustering of the samples. This means that every sample is ordered, or the samples are ordered here based on how similar they are. So the closer they are together, the more similar they are, and the further they are apart, the more different they are. Here at the top, you see again the color coding. Here in this case, the red samples are the tumor samples, yellow samples are adipose tissue, blue is connective tissue, and the purple is skeletal muscle. And you can clearly see that the tumor samples kind of have a completely different profile, let's say, from the other tissue types. And you can see this represented again here in its principal component analysis, where you see the tumor samples are forming a distinct cloud, which is separate from the other normal tissues. So we can now start to look at what proteins we find where. And when we kind of compare what proteins we find in tumor and in the other tissues, we have 1,400 odd proteins, which we only found in tumor tissue samples. Now, if we then zoom in, we even have 179 of these proteins that we detected in every single tumor sample, but in none of the normal tissue samples. So these could, for instance, present potential tumor markers for perivascular wall tumors. And we're at the moment trying to work through this list and trying to figure out which might be good markers among these. So if we now compare all the 4 different subtypes that I just told you that we've analyzed so far, so the fibrosarcomas, the mix of fibrosarcomas, the peripheral nerve sheath tumors, and the perivascular wall tumors on this is RNA data. We can kind of, again, look at this heat map, and you can appreciate maybe, again, that you kind of, the similar, let's say, the same subtypes are roughly clustering together. So mostly the blue ones are sticking to the blue ones, but that's actually not true for all of them. And you have here this big cluster of yellow ones, but it's not absolutely perfect. This is what it looks like in the principal component analysis. So you can identify clusters of different subtypes. Here, for instance, in red, the fibrosarcoma cluster. Then we have down here this peripheral nerve sheath tumor cluster in yellow. So, you know, mostly the tumors seem to behave roughly how we would expect them based on the histopathological diagnosis. So you can, however, appreciate, and maybe we will zoom in on that more on the other slides, that we also have, for instance, in this perivascular wall tumor cluster up here, in this green one, you also find yellow and blue dots, which are myxofibrosarcomas or peripheral nerve sheath tumors. So clearly, there is, you know, a certain amount of misdiagnosis when you base your diagnosis only on histomorphological criteria, which on the molecular level, these tumors tell you something else. So let's zoom in a bit to make this point a bit more. This is just concentrating now on fibrosarcomas and myxofibrosarcomas because they're thought to be very, very similar and thought to be potentially starting from the same cell of origin. So in orange, you see the fibrosarcoma, and in yellow, you see the myxofibrosarcoma. And clearly, what you can see is that these are not 2 distinct clouds. There is quite a lot of overlap going on. So it's more like, I always say, for me, it looks more like a gradient, you know, starting over here. Then you have a transition zone where you find both of these subtypes. And then you have more the myxofibrosarcoma-like end of the spectrum. So for us, this looked very much like it was not a fibro or myxofibrosarcoma do not represent 2 different entities, but more like a molecular continuum of the same disease. So we wanted to further assess how similar or different these 2 subtypes are, and we performed so-called competitive gene set testing analysis. And this means that we ranked the genes which we found in canine myxofibrosarcoma from the lowest expressed one to the highest expressed one here along this x-axis. So you have the very low ones over here and the very high expressed ones over here. And then you take the top 50% expressed genes in the other data set, in the fibrosarcoma data set, and you just see where along this axis are these genes that you find. And as you can see here from this running sum of statistics and also, you know, these bars, which really intensify towards the right and get much more dense, the red ones, clearly the genes which are highly expressed in fibrosarcomas are also highly expressed in myxofibrosarcomas because they really accumulate there to the right. And the blue bars down here, they show the same thing for the lowly expressed genes. So really, whatever is lowly expressed in myxofibrosarcomas is also lowly expressed in fibrosarcoma. So from this and from some other analysis we've done, which I won't bore you with now, we think that canine fibrosarcoma and myxofibrosarcoma really represent the molecular continuum of the same disease rather than being a different disease entity. So it's more a matter of differentiation grade, if you want. And I told you that they're very similar, but then you probably also noticed that there's this one group which behaves completely differently. The one group that I outlined here is C1. It seems to live on an entirely different planet than these up here on the left. So this group consists of 14 diagnosed myxofibrosarcomas and 1 fibrosarcoma. But obviously, they are something different because they are not the same like the ones over here. So to understand what is special, if there is something special about these, we performed so-called fusion gene identification. So in soft tissue sarcomas, fusion genes are, especially on the human side, we don't really have data on that on the veterinary side, or very much data on that yet. But in humans, it's known that fusion genes are very important drivers of soft tissue sarcoma development. And when we did fusion gene analysis of all these tumors that you see here, we found that in 7 out of these 15 tumors, which are clustering down here on the right, they shared the same fusion gene. So we could detect one and the same gene fusion in almost half of these tumors. This suggests that this actually represents a different subtype in dogs, a different soft tissue sarcoma subtype, which is currently, which hasn't been described so far. Now, this just kind of drives home, I think, the point that histomorphology does not tell you everything. It's a bit like looking at these two pictures here. At first glance, they look like 2 different dogs, but if you look at it more carefully, or maybe if you just know the history behind it, it's the same dog just before it went to the trimmers and after it has been there. So it's the same dog looking completely different, but still it's the same dog. So it might also be the same thing, or it looks very much like it's very similar with histomorphology when it comes to soft tissue sarcoma diagnosis. So we have to use more than just imaging based analysis for proper diagnosis of these tumors. Good, and then coming back to the PCA here, we actually find these tumors which have a special fusion. We can also here in the PCA, we can distinguish them from the rest. So moving on to the perivascular wall tumors and peripheral nerve sheath tumors, which are very, very different difficult to tell apart using histomorphology. And we actually, I didn't tell you yet that we used immunohistochemistry to try to, based on the current standards of diagnosis in the veterinary field, to try to really classify which ones either of them are. And here you can see a heat map of the 552 most significantly deregulated targets between these subtypes. And there are a couple of interesting things to note here. First of all, we have here a big cluster of samples on the left, which in green here, they are peripheral nerve sheath tumors. And this is nice because that means that it seems that the diagnosis was correct and they really are similar. Also here I brought you this annotation with an asterisk, which means that these cases are tumors where we could really see in histomorphology that they are deriving from a nerve, which suggests that they really are peripheral nerve sheath tumors. However, if you look at this big cluster here more in detail, what you can actually realize is that it's two different subtypes. So this expression pattern is completely different from tumors in this group over here. So we have basically two subtypes within this cluster of peripheral nerve sheath tumors. So then we were wondering what they might be, but I will show you that in just a minute. First, let's go through the rest. And we have here this cluster, which we kind of failed to detect a proper signature for. And I will tell you, I will get back to these in a couple of minutes as well. And then we have this cluster here on the right, which is mostly composed of perivascular wall tumors, but there are also a couple of peripheral nerve sheath tumors, the green ones you see here, which are, despite being classified by histomorphology and immunohistochemistry as peripheral nerve sheath tumors on the molecular level, they actually associated with perivascular wall tumors. So let's start looking at what these might be. So the peripheral nerve sheath tumors, the two subgroups. It's interesting that the first subgroup here in the highly expressed genes, we find classical peripheral nerve sheath tumor markers like NGFR, SEX10, and GFAP overexpressed. Whereas in the second group, these are not overexpressed, but instead we find laminin A1, S100B, and EGFR being overexpressed in these. So this, especially the EGFR, then reminded us of the fact that actually in humans, peripheral nerve sheath tumors come in two different flavors. One is the spindle form, and the other one is the epithelioid form, which are considered to be more malignant than the spindle form ones. So we sent our cases to our collaborator, physician pathologist, and he just pretended these are human cases. And he diagnosed them, and he actually diagnosed them based on their really molecular workflow as malignant peripheral nerve sheath tumor of the epithelioid variant. So the ones over here, and the ones over here as the spindle forms. So it really looks like we have the same two subtypes as in humans. We also find them in dogs, and we were not aware of this before. Good, and then the third cluster over here, which is mostly composed of perivascular wall tumors. There are some interesting findings, including that most of these highly expressed genes are still associated with neuronal system and glutamate neurotransmitter release cycle, which kind of begs the question, are these perivascular wall derived, or are they also some kind of nerve tissue derived? And I can't tell you yet, but we're trying to look into this. So the question where perivascular wall tumors really originate, what cells they originate from, for me is at the moment unresolved. So then we can do some other things which we're very much trying to dig into using these data. We can, for instance, use so-called hallmark gene set enrichment analysis. So where we take all of these, all of the expression patterns that we find for every sample and try to figure out which pathways or which signaling cascades are activated in these. And by doing so, we can differentiate between tumors which have a very large amount of immune-mediated signaling and those that basically have no immune-mediated signaling going on. And then we also have those which have very high amounts of cell cycle-related genes or signaling activities, whereas others might not. And unfortunately, we do not have good follow-up data on these cases. But as I told you, we also have human data from myxo and fibrosarcoma. And there we have good outcome data. And I can tell you that these two classes, they stratify the human soft tissue sarcomas extremely with regards to overall survival and disease-free survival. So we're still trying to figure out whether this could help us determine how aggressive these soft tissue sarcomas are in the dog. So the association with aggressiveness and outcome, we're trying to work on it. And of course, you can also start to figure out whether some of these tumors might be amenable to novel approaches such as immunotherapy. So, and to try to really go into detail on the immune side of things, because the immune cells start to really pop up as quite important differentiator, especially on the human side with regards to overall survival. We have started to do so-called single-cell RNA sequencing of, it's actually now already 12 patients, so fresh tissue that we got from surgery, which we analyzed to figure out what these tumor cells and what immune cells are present in these samples, and always comparing to healthy samples from the same dog. This will help us to validate tissue specificity of novel markers. We can start developing tools to figure out how many immune cells are in our other data sets, and understand if immune-specific changes in soft tissue sarcomas might be amenable to immunotherapy, and then also develop further fancy techniques. So to conclude, comprehensive transcriptomic and proteomic characterization of canine soft tissue sarcoma subtypes, including relevant patient-matched normal tissues. That's what we're working on, and we've already, gotten, I think, quite far. We're still far away from being at the end of it, but yes, I think a lot of interesting insight already. So soft tissue sarcoma subtypes are characterized by distinct transcriptomic signatures, which might have diagnostic relevance. So this might support our accuracy of diagnosis at some point. Then we have identified a potentially novel canine myxo- fibrosarcoma-like soft tissue sarcoma subtype, which is characterized by one specific gene fusion. And we've identified novel subtypes in this perivascular wall tumor, peripheral nerve sheath tumor spectrum, which we didn't know of before. And just overall, this spatially defined proteomic and transcriptomic analysis of archival samples really helps you to figure out what's going on the molecular level in your samples. And the beauty of the system is that it's species agnostic, so it doesn't matter whether you're looking at dog tissue, at cat tissue, or a hedgehog. You can run it across all of them. And we're working really quite intensely on trying to figure out which might be good targets to improve surgery, because our surgeon here, our soft tissue surgeon, she's very much into using these kind of techniques, and trying to really assess clinical impact of molecular clusters and also refine diagnosis of these soft tissue sarcoma subtypes. So I'd like to close with acknowledging all the people doing the work. So these are some people in my lab. You can see them listed here, and I think I acknowledged I mentioned all of them on the respective data slides. A huge shout out to our soft tissue surgeon, Mirjam Nolf, who's really a big driver also behind these projects, our pathologists and everyone else, and also all the funding agencies to kind of provide money, because these analyses are very costly. And thank you for your attention.
Kiitos paljon, Enni, mahtavasta esityksestä. Tosi mielenkiintoista oli kuulla, miten voi käyttää multiomiikkaa tai tämmöisiä uusia teknologioita, erityisesti pehmytkudossarkomiin liittyvässä tutkimuksessa. Näyttää siltä, että paljon on tehtävää, mutta hirveän lupaavia tuloksia. Ja on aikaa vielä kysymyksiin. Katsoin, että tuolla Q&A:ssa ei tällä hetkellä ole kysymyksiä. Meillä tuli ennen tätä webinaaria pari kysymystä, jotka me voimme ottaa alta pois. Ensimmäinen oli ihan tällä DeepScan firma.